Okay, this chapter will discuss injury and pathology of the elbow. Um, in reality here, there's not all that much, so compared to the shoulder, the elbow is very straightforward. We're going to deal with acute trauma for the most part. Toward the end, we will deal with a couple chronic conditions, but in the grand scheme of things, most things that happen to the elbow are a result of an acute injury. So starting off here, elbow dislocations are the not very common, but if they do happen, 90% of dislocations are going to happen posteriorly. So when the elbow does dislocate, the humerus is going to move forward and the olecranon of the ulna is going to move posterior. So when we say a posterior elbow dislocation, it's where the olecranon is going, where the olecranon process is going. So in this case, the olecranon is moving posteriorly in these situations. In order for a dislocation to occur, it's going to have a very large force. You guys understand the anatomy. We have the olecranon that wraps all the way around the trochlea of the humerus. It has the coronoid process in the front, the olecranon process in the back, and it is a very stable bone-on-bone joint. So when we talk about a lot of stability, the elbow has a ton of static stability in the makeup of the bones. So it's going to take a fairly large force in order to actually dislocate the elbow. And actually to have it happen though, posterior most common because of the axial load. So when you do apply an axial load, so a longitudinal load through the forearm while the elbow is slightly flexed, that's going to be the primary way we dislocate the elbow. We're not even going to talk about anterior dislocations when the olecranon is actually in front of the humerus, really, but in order for those to happen, it would have to be a major traction force. So in order to get the olecranon to dislocate anteriorly, something has got to pull very hard on the forearm in order for it to come out that way. So in athletics, we don't really see that. Maybe in some sort of gymnastics where your body weight is hanging from your arms, but it is not very common at all. When you see an elbow dislocation, it is pretty obvious. Very obvious deformity. The forearm is going to appear shortened on the side of injury because the entire forearm has actually moved posteriorly. So if you do compare it bilaterally, the forearm of the injured arm will be a lot shorter. Obviously, you're going to be in severe pain and you're going to have complete loss of range of motion at the elbow. It's going to be stuck because that joint is no longer there. You're not able to do flexion, extension, or supination, pronation because that joint is no longer articulating, so range of motion is not going to occur. When you look at it, the olecranon is going to be very high and prominent posteriorly. It's going to be sticking out, so you can see that the olecranon does stick out. It is very obvious. You get this big bulge on the posterior elbow. Rapid swelling, and you have to be careful of a possible bicep tendon rupture, which I'll talk about in a second when we look at different pictures. Whenever you have a fracture or dislocation, especially in this area, you want to check neurovascular function because you understand the structures that run through this area. You have 3 major nerves and a major artery that run directly around the elbow. Your median, ulnar, and radial nerves and your brachial artery are all in the location of the elbow. So you really want to make sure that they have full neurovascular function. So you can check distal pulses, check capillary refill, check sensory and motor function because you want to make sure that the dislocation itself is your worst problem and not the dislocation plus a severed nerve or plus a pinched or severed artery. That's going to end up becoming a bad joint problem to a possible limb-threatening and maybe even life-threatening problem if you actually did sever the artery. So make sure that you always check the distal arteries and nerves. When you do see one, you splint as it is. Do not reduce. Again, that's going to be because the athletic trainers, number one, do not reduce. We're not trained to. But because of there's so many structures, those structures that are in the area, if you do try to put it back, and then you sever an artery or sever a nerve, then you're going to be found liable and negligent and could be sued and found guilty. So you never ever reduce ever, but especially never ever reduce the elbow. There is something called the terrible triad of the elbow. This is a combination of things that make it extra terrible, so it's worse than just a regular dislocation. It's the posterior dislocation plus a fracture of the radial head plus a fracture of the coronoid process. So you have the posterior dislocation plus a fracture of the coronoid process and the radial head. So it's even worse than a regular dislocation. If you guys remember last year, Tyler Eifert for the Bengals He, first game of the season, dislocated his elbow and was out for the entire season. So here's kind of the play-by-play. He caught the ball, ran down the field, got tackled. You can see that he is ready to land with his elbow in a flex position. Then he does finally land with his entire body weight plus gravity forcing him down. He does end up landing on a flexed elbow. It ends up dislocating, and you can see him laying here. And here is that bulge where the humerus is actually moved anterior, and the olecranon down here has moved posterior. And then the x-ray would, this is not actually his x-ray, but it would look something like this, where the olecranon is now posterior and the humerus is anterior, giving it that funny looking shape. So it's not very difficult to diagnose an elbow dislocation. In this case, again, we splint, we check neurovascular function, and get into the hospital immediately. There is commonly associated fractures with dislocations. You can see how this one is not fractured, I don't think, but because the coronoid process is sticking up really high in the normal joint position, in order for the humerus to come forward or the olecranon to move backwards, it would be very easy to fracture the coronoid process. You can also see the radial head sitting back here. The radial head can also, depending on how much force there is, can be fractured, and that gives you your terrible triad. So the would be the dislocation plus the coronoid process plus the radial head would give you your terrible triad. Here's some more pictures of your elbow dislocation. Again, very obvious, very prominent olecranon process there. You can see that the entire humerus is shifted forward here, and the olecranon's back there, and the same picture as before. I said I come back to the distal bicep tendon rupture. Remember that the bicep tendon is going to insert on the radial tuberosity. So if the humerus does come forward enough or the forearm moves posterior enough, you could end up kind of just pushing the entire bicep forward and possibly causing a rupture of the bicep tendon as well. So just be aware of that. Other fractures we have that are around the elbow. The supracondylar fracture. So again, if you remember what the humerus, the names are, we have the humeral shaft, and then we have the supracondylar ridges, where if you look at the humerus from the anterior side, you can see as it starts to flare out. Those are called supracondylar ridges. In this case, supracondylar can mean above the condyles, so a fracture that is above the medial and lateral epicondyle. So in this case here, this is the medial side, so this is the medial epicondyle right here. So this fracture is not really on the regular shaft, it is on the distal part right above or at the supracondylar ridges. So a distal fracture right above the condyles at the elbow. It is above the distal growth plate, so it's just kind of a regular fracture. It's just not in the middle of the shaft, it's down further. You get this falling on a flexed elbow or possible hyperextension. So if you do hyperextend it, it could fracture right there. Again, pretty obvious when it comes to any kind of fracture. You're going to be in pretty intense pain, and usually you have very rapid swelling. Depending on how bad your fracture is, there could be a possible angular deformity of the humerus. So it could, if it is fractured like this, it's going to be very obvious. There's going to be, if the elbow is not going to be shaped correctly, there could be an angle in a different way, but it is pretty obvious, very point tender. If it's not displaced like this, it's going to be a little bit less obvious, but still a ton of pain with any kind of movement. So they're not going to really want to move their arm at all. And then just like I said with the dislocations, anytime you have a fracture or dislocation, you want to make sure that you check that neurovascular function. An olecranon fracture, this is more common in skeletally mature patients. The bones are a little bit harder, and then they're actually more susceptible to fracture if the force is large enough. So in order to actually fracture your olecranon, any part of your olecranon here, usually it is from a direct blow or you fell directly on your elbow. So if you actually, it has to be basically a direct trauma right to it. There could be an associated fracture like this with a dislocation, but not always. This is definitely more from a direct blow. With this, you're going to have severe pain, possible crepitus, you're going to have deformity. There's going to be, if you palpate this, you are going to be able to feel that gap. And you're going to feel that because, if you remember, your tricep tendons are going to come down the posterior side of the arm, the humerus, and they're going to insert into the olecranon. Well, if the triceps are not impaired, they're always going to be pulling up. So even when you're relaxed, your triceps are still going to contract. So they're going to be pulling this part of the fracture up, leaving you that dip here, because this part of the bone is going to be stable because it's wrapped around the trochlea and it can't go anywhere. So the triceps are going to pull this part back, and you actually could feel some sort of gapping there because the triceps pull that part away. Obvious swelling, possible bursitis, so you can have even more swelling if you did have direct trauma right to your elbow. And then obvious loss of range of motion, especially with elbow extension. When you extend the elbow, you're going to end up bringing these two broken parts of the bone together, and they're going to hit, and that's going to cause a lot of pain. So there actually finds some relief in flexion and more pain with extension because the two ends will be bumping together. Same thing with this one. You're going to end up splinting it and checking your neurovascular function and getting under the hospital. Radial head fractures are most common either with a dislocation, which is part of the Fuchs mechanism, or any other regular kind of Fuchs mechanism. So falling on an outstretched hand can also cause a radial head fracture, where it actually, the radial head is pushed up into the capitulum of the humerus. So when we fall down here, the force travels along the radius and jams these two together, causing a fracture of the radial head. Like I said, it also can occur with dislocation. Because of what the radial head does, it does flexion, it helps with flexion and extension, and it does supination and pronation. So those two movements occur around the radial head and capitulum. So when you do them, they're going to hurt. So you'll know that the radial head is involved if those motions hurt. Depending on how bad this is, with this fracture, it's pretty, it's not displaced or anything. This one's going to cause pain. If it's bad enough, there could be pieces or chunks kind of floating around in here. That's going to be even worse of a situation. So if you have a displaced fracture where there are pieces or multiple things going on in here and it's not still intact, you're going to have to get surgery, and we call that an ORIF. Open reduction internal fixation is your ORIF. Because we actually have to go in there and pin those pieces back together, or else you'll have loss of function forever because they're not going to end up growing back. So if it's in multiple pieces, you're going to have that surgery. Depending on how bad it is, your surgery can vary. If it's a pretty, only maybe like 2 pieces, like you have the majority of the radius and then you have a little piece over here, they can just put pins in it and put it back together. If it's even worse, they can put pins in plates depending on what they feel like doing. And I thought this was pretty cool. They can actually replace your radial head. So if it's bad enough, they might just remove all the pieces, actually cut off the rest of the radial head and put on a new radial head so you can gain back that full motion. So just kind of keep that in mind. There radial head fractures, if there's more than one, if it's displaced, you're going to have surgery. Forearm fractures up by the elbow. Again, these are pretty straightforward, regular types of long bone fractures. Obviously, the easiest ones to deal with. They are not displaced. They're not popping through the skin, where it's just a regular fracture. But then you can actually start, if they're worse, you can start classifying based on if it's an open or closed type of open or closed / simpler compound. Is it displaced? Is it coming through the skin? How bad is that actual fracture, and how many bones are involved? And then is there any kind of angulation or rotation or displacement? So something like this is obviously very severe, where we actually have displacement of either the radius or ulna, or both the radius and ulna. Very problematic. Get them to the hospital immediately. And also make sure that you watch your distal pulses and your neurovascular function, just because, again, there's a lot of stuff running through that area. You want to splint this as quickly as possible because those bones are fractured, and if they are displaced, you have very sharp parts of the bone that could end up severing the arteries or nerves, again making that fracture into a very serious problem. Remember that when you do immobilize any kind of bone itself, you must immobilize both joints around it. So if the forearm is the problem, that's where the fracture is, you have to both immobilize the wrist and the elbow so that no movement occurs along those bones. Remember that if a joint is involved, then you stabilize the bones above and below. But if a bone is involved, you stabilize the joints above and below so that no movement occurs and no further damage is going to occur. So those are the main bony injuries. Then we're going to get into the actual sprains here. Most common in the elbow that we see is an UCL sprain, an ulnar collateral ligament sprain. This is very common, especially in overhead throwing athletes or volleyball players, or tennis players, people who do that throwing or overhead motion. If you remember, when you go through that throwing or hitting, overhead activity motion, there's a lot of valgus force placed on that elbow, and the valgus force is from the outside in. And although it's not in someone else applying the force, it's internally developed through the throwing motion. It is still a very high force where you actually have compression of the structures on the outside and stretching of the medial structure. So that valgus force results in the stretching of the structures on the medial side. So you have your UCL in there, your three bundles of the UCL, the anterior part, the posterior part, and the oblique or transverse part. We also have a couple other structures that are there to help dynamically stabilize. So remember the difference between static stabilization and dynamic stabilization. Your static stabilizers are going to be your ligaments and your bone, makeup of the joint. Your dynamic are going to be the muscles, because they're the ones that can actually contract and help. So at the medial side of the elbow, the triceps and the anconeus are going to help with medial stabilization or dynamic stabilization during this motion. And the wrist flexors. The wrist flexors do cross the medial side of the elbow, and they are going to also help with dynamic stabilization. They're just, how they're positioned, they're not able to help as effectively as other dynamic stabilizers in the body. So when you actually do get a UCL sprain, it's from a valgus force, whether it's generated through the throwing motion causing a tensile force, or like in football players or something where they actually get hit from the lateral side and end up spraining their UCL. Whatever it is, the way to hurt the UCL is through a valgus force. So it could, again, be through that lateral force, or it could be through overhand throwing or hitting when you go from that cocking to the acceleration phase. So we're going to actually get into and understand what's going on in the throwing motion. So what I want you to know through all of here are the different parts. So in the actual pitching or throwing motion, you have the wind-up phase. So whether you're a pitcher or you're just a regular thrower, there's a phase where you're going to actually have to help generate force. So you go through some sort of wind-up position to get your arm in the correct position. So whether you're throwing a baseball, a softball, you're hitting a volleyball, hitting a tennis ball, whatever it is, you're going to have to go through something to get your body in the correct position. That's considered the wind-up. Then the cocking is when you're going to actually bring your arm back, whether it has the ball in it or you're getting ready to hit. Whatever it is, you bring your arm back, and you're going to prepare to actually hit. And then the acceleration phase is the transition at the very end of cocking, when you're in the proper position and you're ready to actually do the motion. That's when the acceleration phase kicks in. And then after you release the ball or hit the ball, then you're going to go through deceleration and follow through to slow your body down. When it comes to UCL injuries, it's going to be the cocking/acceleration phases that are going to be really the most problematic. The very end of cocking, when you're bringing the ball all the way back, in the transition from cocking, where you're moving backwards, to acceleration, where you move forwards, is the most stressful on the elbow, on the UCL. The most valgus force is applied in that transition. And then it stays pretty high through the entire acceleration phase. So we've also talked about a couple shoulder injuries that involved the throwing motion, obviously. And we see a lot of posterior shoulder tightness because of the deceleration phase and the follow-through phase, where we're trying to actually slow our shoulder down. We see a lot of posterior capsule tightness when we try to slow the shoulder down during the deceleration phase. So understanding the throwing motion when it comes to injury diagnosis and rehabilitation is going to be really important. So really what I want you to know, and the questions that are going to be on the test, are going to be which muscles of the elbow and which of the shoulder are contracting, and how are they contracting. So for example, during the cocking phase, understand what the cocking phase is. You're going to end up bringing your arm back, so you don't have to memorize all these positions if you understand what it looks like and you can actually do it. So you bring your shoulder back. Obviously you're going to be a max external rotation, and your shoulder is going to be abducted to 90 degrees. So you don't have to memorize that if you understand what the motion is. But the elbow position is going to be at approximately 90 degrees of flexion, and we're having increased valgus force. But really here, in order to get the shoulder into the proper position, we're going to have to concentrically contract the external rotators, and in order to regulate how fast it is going, the shoulder internal rotators are going to have to slow it down eccentrically. So again, I want you to understand concentric, which ones are working at the elbow and the shoulder, and then which ones are working at the elbow and shoulder eccentrically. As we start to move into the acceleration phase, we're going to pull very hard with our internal rotators concentrically, and we're going to have to slow it down with our eccentrics, with our external rotators eccentrically, and that's going to stay through there. So using this, I want you to really understand this section right here, as well as what is going on in each part of the throwing motion. And then here, let's see if it'll work. Here is a YouTube video. Come on. Of a baseball pitcher, Zach Greinke, in super slow motion. So in this phase right here, he's going through the windup. He's getting his body in the right position. He's generating force from this position. In the throwing motion, it's really important to use a lot of legs. Now he's winding up. Now he's got to get his arm in ready to actually throw. So you see that coming. This is all considered the cocking phase, where he brings his arm back, getting ready. Now he's starting to move forward into the acceleration phase, and right in there is where we're going to have the most force. If you're going to tear your UCL, it's going to be in that position right before where his arm was about 90-90 position. Tons of force on the elbow. And then as he decelerates and follows through, that's going to have a little bit more force on the posterior capsule. So with someone who does get an actual UCL sprain, it's pretty easy to diagnose because it's going to be point tender right over the UCL. So you are going to have pain on the medial aspect of the elbow. It's going to increase with any kind of motion, especially when it's taut. So flexion tends to be a little bit more painful than extension because we have more of the fibers that are painful during flexion. But they are still taut during extension, especially the anterior bundle. So both flexion and extension can cause some pain. You have to be careful because if you remember your anatomy, we have our UCL right here, anterior band, posterior band, and transverse band. And then we have our ulnar nerve running right on top of that. Then we have our flexor tendons, our wrist flexor tendons, covering all that up, forming the cubital tunnel. So if we do sprain these ligaments or even rupture them, there's going to be a lot of swelling in the area, and that swelling is going to put compression onto that ulnar nerve. So there could actually be not only pain at this site where you actually sprained it, but you could also have numbness, tingling, paresthesia, loss of sensation, because you actually are compressing the ulnar nerve. So it could be not only a UCL sprain, but also you could actually put compression on the ulnar nerve. Possible swelling over the UCL, the medial elbow, point tenderness, especially over the anterior bundle. If you're able to flex it for more than 60 degrees, then the posterior band might also be involved. And like I said, pain with range of motion, probably a little bit more flexion, but there could be some pain with extension. This is going to be the same whether we're dealing with a pitching-related UCL problem or from any kind of traumatic event, like in football, where if you get you can also get a UCL sprain. Linemen actually get them a fair amount because their arms are extended and they get hit from the side. That's all valgus force. So we actually see this a fair amount in football as well. So either way, they're going to have the same kind of signs and symptoms. In most cases, we're going to deal with the anterior bundle. That's because it's taut throughout the entire range of motion. So it is the strongest, but it's also the most susceptible to injury. If we have pain and we find they have pain with more than 60 degrees of flexion, then your posterior bundle can be involved. We generally don't have much trauma at all to the transverse or oblique bundle because it doesn't connect to the humerus. Special tests, you should get a positive valgus stress test and probably a positive moving valgus stress test because when you apply that valgus force, this will cause pain and possible laxity. So when you do the valgus stress test, you're looking for not only pain, but how much laxity or how much gapping does occur within that joint. If you have a full UCL tear where it is completely ruptured, you generally have to get some sort of surgery, very common, called Tommy John surgery, very common in pitchers. Some people, if you are not really an overly competitive athlete, you don't really need to get surgery. but if you do want to continue doing the overhead activity, you are going to have to get it. If it is more of a grade 1 sprain versus a complete rupture, then you'll just do your conservative treatment where you'll actually let it heal. But if it's completely ruptured and you want to continue that level of activity, you generally have to have surgery. And this is Tommy John surgery, and it's actually a pretty cool surgery. They're going to end up taking this is your palmaris longus, and they actually just pulled it out. Your palmaris longus it's part of that medial flexor group, and it's got this little tiny muscle belly up here and a very long tendon that goes right into your palmar fascia. So what they actually do is snip it down here, snip it right here, and use this as your new piece for UCL. Now, there is a certain percentage of the population that does not have a palmaris longus. So if that's the case, they started using your hamstring tendon like they would for an ACL. So part of your hamstring tendon or your palmaris longus could be used there. So here's your elbow in full extension over here. Here's your anterior bundle, your oblique bundle, and your posterior bundle. And most likely your anterior bundle and probably some of your posterior were actually ruptured. So to fix that, we're going to basically create a new one. So they're going to drill holes in your, by the coronoid process down in the ulna here. And they're going to also drill holes in the medial epicondyle. They're going to take this tendon and they're going to actually just sew it through here. They're going to figure eight it through and basically anchor it in, and this is going to be your new UCL. So this is actually called a docking technique. Here's another picture of it on the last slide, where they just take it and they basically just sew it through medial epicondyle in ulna, and now you have a new UCL in there that's been sewed through. This is actually, they found that after this surgery, this new UCL made from the palmaris longus or hamstring tendon is actually stronger than your original UCL was. This is why Tommy John surgery is becoming very popular. Number one, people are throwing a lot harder and a lot younger, so we're seeing a lot more tears. Number two, this surgery is very successful. It started off, if you used to tear your UCL back in the day, you were done with your career. The surgeries were not very good. Now the surgery is actually very successful. It still has a very, I think it's about a 6-month recovery period. But afterwards, people say that they throw a lot harder. And they say they're able to throw a lot harder because their UCL is now stronger, so they can actually produce more force. Whether that's true or not is up for debate. But there is, always these topics of how parents want their kids to go under voluntary Tommy John surgery so that they can throw harder. People say that it's not true. You do actually can throw harder, but you're throwing harder because you've been doing intense rehab and strength training during your recovery. So the reason you're throwing harder is not because you have a new UCL, it's because you've actually been training a lot harder, which is why you're throwing harder. Either way, it's kind of a hot topic right now. I think it's a pretty cool surgery. And it is very successful, and there's a good chance you're going to end up running across this. If you don't get surgery and you just want to let it heal, which is a good option, basically you have to rest. You have to alleviate those repetitive forces or rest so you don't continue to rupture what's healing. You can use modalities and NSAIDs to decrease pain, and then as it's healing, you work on range of motion and strengthening. So this is the way that we're able to really kind of let this area heal if it is not a complete rupture. If it's a rupture, then there's a good chance you're going to have to get surgery. Okay, we'll stop there on part 1 and pick up again with the rest of them on part 2.